I think my big message to patients when they're diagnosed is that they often feel that their body's a failure because they've got diabetes. They're not very good at being pregnant. And I like to reframe it and say, actually, gestational diabetes is just being pregnant, but a bit more so. So I quite like making it more of a positive way of thinking about it, because I think it is a really hard diagnosis to have. It's really difficult and it takes an enormous amount of work. And if your baby grows a little bit more than we had hoped, then it feels like you're a failure. And I think it's trying to just reverse that round and say, let's make this a positive experience.
Great. Welcome to this episode of UMBI's Pregnancy Podcast. I'm Dr. Sujitha Selvarajah, obstetrician and gynecology doctor and founder of UMBI. Joining me for today's episode is Dr. Caroline Ovadia for our episode on gestational diabetes. I'm going to introduce you. Are you ready?
Of course.
You are well, this is not what you said, but I think you're one of the world's leading experts on diabetes in pregnancy and also metabolic disorders. Caroline is a clinical senior lecturer at King's College London. You're also a consultant obstetrician at Guy's and St Thomas's Hospital. You specialise in metabolic maternal disorders in pregnancies, and that includes diabetes, cholestasis, and dyslipidemias. I think I'm going to be out of breath by this introduction. But you're the obstetric lead for diabetes in pregnancy here at St Thomas's Hospital, which is where we're at the moment. You've also done so much academic work in these fields, and also kind of better understanding these conditions and also how they affect mums and babies. Your work has influenced international guidelines. I was just telling you how much I love your guidelines, and your work has been cited and has changed practice all over the world. You're a medical advisor to the baby loss charity SANS and also other charities, and you're a maternal medicine representative for the British Maternal Fetal Medicine Society. You're also an academic lead at King's College London, so you're teaching medical students, helping them understand research methods and how to apply, statistics to their modules. Yeah, I could have done with some of that. But I guess the main reason is you're one of the world's most knowledgeable people on diabetes and cholestasis in pregnancy. And not only do you know so much, I feel you've contributed a lot to what we know. Right, let's get into it. What is gestational diabetes?
So gestational diabetes is basically defined by blood glucose concentration. So the amount of sugar that you have in your blood is above a standard level. It's slightly different numbers in different parts of the world, and nobody's really decided what should be right, and we haven't got a good consensus. But we manage blood glucose levels because if they're too high, we know that they can be associated with problems for the growth of the baby, problems in the pregnancy. So essentially, gestational diabetes is having too much sugar in your blood, either before or after food.
Got it. And how is that different? How is diabetes in pregnancy different from diabetes outside of pregnancy?
So gestational diabetes refers to diabetes just in the pregnancy, whereas there are many patients now who have pregnancies where they've had diabetes before, so type 1 or type 2 are the most common. But we don't know for all patients with gestational diabetes if they've just never known. So that's why gestational diabetes, you can really only 100% tell someone they've had gestational diabetes after the pregnancy when they've had a blood test saying, no, you don't have diabetes anymore. But essentially, anybody who's diagnosed in their pregnancy with blood glucose levels above the concentrations that are sort of your local target level.
Yeah. My understanding is a little bit different if it's just diabetes in pregnancy, that it's to do with some of the hormonal changes. Can you tell us a little bit about that?
Yeah, so there's sort of two main things that control your blood glucose. One with your blood glucose is how much insulin is produced by your pancreas. When you have some glucose, when you eat something, signals go to your pancreas, it releases insulin. And insulin is a hormone that goes all around your body, all around the tissues in your body, and helps the tissues uptake glucose. So it takes glucose out of your blood. Insulin levels in pregnancy don't particularly change, but the ability of your body to respond to that is what changes. So insulin resistance is one of the reasons why women get diabetes in pregnancy. Their body doesn't respond to this signal coming from insulin. So we think there's possibly two different types. One, which is women who aren't having enough insulin secreted for their pancreas, and the other group where women are having a resistance to it, so they can't respond.
Insulin is there, but they're not responding to it.
Yeah.
Okay. How does gestational diabetes affect mums?
So in terms of the impact on mums, firstly, having higher blood glucose concentrations, most people wouldn't be aware, but there are symptoms. Some women they'll pass urine more frequently, which is one of the ways that we diagnose diabetes outside of pregnancy, because glucose in your kidneys actually makes you produce more urine. It's one of the stimulus to make you go to the toilet. So you may get symptoms of that. Some women, if they've got very high blood glucose levels, they may have things like thrush a little bit more commonly, because the sugar in their tissues is quite a nice environment for thrush. But the vast majority of patients won't have any knowledge that they have gestational diabetes. So in terms of at the point of diagnosis, the vast majority of people won't know about it. And that, I think, is one of the hard things.
Well, I was going to say, I find this quite difficult, or I feel that this is one of the difficulties in this interaction, because these are people overall, compared to most of the population. If you're in your 20s and your 30s, you're not that unhealthy for most people. Yeah. And you're pregnant, and you know, even in those early stages, pregnancy is very variable. Yeah. And then all of a sudden, you're a certain number of weeks and you're feeling okay. Yeah. You might even be feeling better than you've been feeling earlier on in pregnancy for lots of people. Yeah. And you've been seeing the midwife, and all of a sudden they're like, oh, your test shows you've got diabetes, now I need to see the doctors. And then they see us, and we're like, well, you need to do this now, and this is the problem, and now we're worried. And I think this is huge disconnect from the person who's pregnant, who's like, wait, I feel okay. I'm feeling a bit better. Why? And now I'm hearing all these big words and scary things to do with risk. How do you manage that?
Yeah. So the way that I like to explain gestational diabetes is being too good at being pregnant. So rather than saying, I know, well, the thing is that I think it can feel like your body's failing. It's not doing what it's supposed to do, because you've got a diagnosis that's putting your baby at risk of things. And we'll talk about that, I imagine, in a little bit. But in terms of actually every pregnant woman gets a little bit resistant to insulin. They get a little bit more glucose in their blood available to pass through the placenta to help support the growth of the baby. And that's a good thing. We need that insulin resistance. And when you have gestational diabetes, I tend to describe it very simply as you've just done it a bit too well. And I think often that's why patients can get diabetes in their second or third pregnancy when they haven't had it before, because their body's remembered how to be pregnant. And actually,
I need to give the baby some sugar. So,
absolutely.
Yeah. So it's quite interesting, that dynamic of actually for most pregnancies, actually normal to be a little bit insulin insensitive, so that baby can have more blood sugar that's available for the babies. Yeah. That's actually a nice way of framing it. Yeah. I also think it's quite, in terms of longer term effects. Yeah. Well, actually, maybe you can say, some people, you say, we test after diabetes, and we can say, after pregnancy, and we say, okay, it's just diabetes in pregnancy. But for some people, we know that actually maybe you had diabetes outside pregnancy, and we've just picked it up. If it is just diabetes in pregnancy, how does that affect your life and your outcomes?
So we know that if you have diabetes in your pregnancy, we have a 50% chance of getting diabetes in your next pregnancy.
I thought it was 33%.
50% is the latest data. A lot of that depends on what you do in the interim. So the good thing about a diagnosis is it's not 100% chance of getting diabetes next time. And we know that inter-pregnancy weight gain is one of the things that can affect that likelihood. So if you're somebody who does put a lot of weight on in between pregnancies, potentially you're more likely to develop diabetes next time. So you've got this risk for your future pregnancies. In terms of your long-term health, you do have an increased risk of developing type 2 diabetes later in life. We do therefore recommend that every patient would have their blood glucose tested. It's called the HbA1c, which is a marker of how much sugar there is in your blood sort of over the 3 months before, done every year. That's quite a big thing to remember. We're trying to work with some of our messaging, some of our computer system messaging in London to make it almost automatic that your GP surgery has it on their register that you need to have your bloods done every year. The reason why it's worth knowing if you have type 2 diabetes is if you manage type 2 diabetes, it can reduce the chance of you having the negative consequences. And that's things like kidney disease, eye disease, heart disease. And we do have medications now, things like ACE inhibitors, which are blood pressure medications that are really good for women with type 2 or patients with type 2 diabetes to reduce this risk of negative consequences like kidney disease. So an early diagnosis, again, it's not something that you want to have a disease, but actually if you know about it, you can do something before you have complications.
Yeah, this is what I think is, I think a little bit helpful is that if you weren't pregnant, you would still have this risk. We just wouldn't know about it.
Yeah.
And so in these months where you're pregnant and you're having more interaction with healthcare systems, it's kind of like a window into what your health is like. And actually, you know that now. You have the knowledge to actually do something about it, because the risk of whether you're going to get diabetes or not doesn't change that much at that point.
Your genetics isn't going to change.
Yeah. But actually, you can figure out, okay, I'm at high risk, so I can do something about it, which I think actually, even if people can't see that way of thinking straight away, because it's a lot of information all at once, that some people are able to see it like that, maybe when they've had some time to process it, which is actually quite helpful.
Yeah.
How does it affect babies?
So the thing that I said earlier, that glucose crosses the placenta to help the baby grow, and that's a good thing. What we need to remember is what happens with glucose. So glucose, when it's in your body, I said earlier, it causes your pancreas to secrete insulin, and it does exactly the same for the baby.
Okay.
Insulin, as well as having actions to lower blood glucose, also works a bit like a growth factor, so it helps babies grow. So what you can see is babies where there are high levels of glucose crossing the placenta will produce more insulin, and they will grow more. So one of the big things that you will notice is that the babies are a little bit bigger. There are different ways that we can measure that, but we particularly look at not just the bony growth, but also some of the soft tissue. So things like the livers get bigger, the adipose, the fat tissue gets a little bit bigger, baby's possibly a little bit chunkier. And if you've got a chunky baby, then giving birth can be a little bit more difficult.
Of course. And I want to ask a little bit about, the ways that we monitor how babies are growing. Why are we so obsessed with the circumference of the tummies?
So it's because of this. It's the soft tissues as well as the bone growth. So what we tend to look at when we look at a growth ultrasound scan, we measure, in general, 3 things. We measure the head circumference, we measure the length of the thigh, and we measure the abdominal circumference. And if you think the head circumference and the thigh, they're measuring bone growth, they're not really giving us such an idea of this soft tissue growth that's going to give us a better reflection of actually, is the baby having overall increased sort of fat tissue stimulus to grow. So when you look at a growth chart, you can see within a population, is my baby at about the 10th centile, which means 10% of babies will be smaller, 90% will be bigger in the leg, the head, the tummy. And if you see that the tummy is, let's say, the 50th centile with the leg the 10th and the head the 10th, you might go, okay, the soft tissue is being driven to grow a little bit more. So that would make me think, oh, there's something happening in the metabolism of this mum that's making the soft tissue grow more, which makes me think it's likely to be related to diabetes.
And it's, we how many times do we see people who in their diabetes test did not have diabetes, but they have a growth scan, and we're like, oh, the tummy of your baby is a little bit bigger, and then we do testing for diabetes, and then they do test for it. How we're talking about babies growing bigger than we would expect, or that their tummy, the soft tissue is growing a bit more, and that could make birthing babies a bit difficult. Can you tell me a bit more about that?
So in terms of there's really good evidence from a massive study called the HAPO study, which looked at women or birthing people's blood sugar levels and their birth outcomes. And it looked at things like the chance of needing a cesarean section, the size of the baby when baby was born in terms of the weight, neonatal unit admission. And what it really clearly showed is that the higher the blood glucose, it's a straight line, the higher the chance of any of these outcomes. So we know that higher blood sugar levels in the mum are associated with a bigger baby. When we look at actually what the sort of outcomes that we can see, the things that we can measure the baby's size, but in terms of birth injuries, we can measure for the mum the chance of having a perineal tear, so a tear that goes towards back passage, called a 3rd or a 4th degree tear, where the muscle around the back passage is torn. That's more likely to happen if you have a larger baby, and that's an additional risk factor. So on top of that, if you have diabetes, so it's almost like you've got 2 things.
And if it's your first baby, 8 or 9 out of 10 people have some degree of perineal tear anyway.
Yes, and it's a sort of normal thing that you need a little bit more space, but actually it's the extent of that tear, is how much of a problem could it cause you, and how difficult will it be to repair. So that's the mum's injuries that is measurably higher when you have larger babies, particularly when mums have diabetes. And then looking at the baby, if the baby is the head comes out but the shoulders get stuck because they've got a little bit more muscle, a little bit more fat tissue there, it's a little bit of an emergency. It's a bit of a thing we're trained for, because at that point the umbilical cord is generally squashed. The baby's stopped receiving oxygen through the placenta and they're not yet breathing because their head's out but their chest isn't. So we need to get that baby born very quickly. The risk when the shoulder is stuck is that in the difficulty of the delivery, getting that front shoulder underneath the pelvic bone, the clavicle, the collarbone could get broken as part of that delivery. And we know that happens more commonly in babies when mums have diabetes, when the babies.
And the nerves, we've got sets of nerves that sit just under here, so there's obviously a high risk of having nerve injury, which for most babies, if they do have it, is reversible. But there's obviously a small percentage that it's not reversible for. It's important also to say, I feel like whenever we talk to patients about this risk of the shoulders getting stuck, it seems terrifying, but it's also important to say that we are all trained. You cannot work on a labour ward. It's impossible to work on a labour ward if you don't know how to manage this emergency. And there are things that we can do, which for most babies, the babies do get born, you know, and our heart rate is often higher than the babies at that point, but they do get born and we actually do know how to manage it. And there's also this thing that for lots of babies that have their shoulders being stuck, it's actually unpredictable. It's not to do with having a big stomach or having diabetes. We couldn't predict it, but we do know there's this association with this happening, and mums having gestational diabetes and babies having their tummies that are a bit bigger.
What's quite interesting to sort of know is actually because of our active management of mums with gestational diabetes, so because of all of the blood glucose monitoring that they do, all of the work that they do with their diet and exercise and medication to get the sugar levels down. If we actually look at the population of women with gestational diabetes compared to the rest of the population of birthing people who are having their children without diabetes, in managed women, we actually have lower levels of some of these complications. We're starting to see that if you really look after patients and they are supported to look after themselves, possibly we're actually helping everybody.
That makes a lot of sense. Two reasons. Because often sometimes we offer an induction of labour, which we can talk about in a little bit, but we're saying we think it would be good to bring forward the delivery of your baby. So then I'm thinking, surely now your risk of this is actually we've lowered it, but we haven't had the evidence to say that. I understand that the reasoning behind it is that actually your risk should in theory be lower if we've done something to intervene. And I guess it's the other thing, if the same thing that we saw with patients with HIV, is that once you actually have good contact with healthcare professionals and we're able to manage it, the life expectancy is just as much as people as the general population. And there were some cases where it's longer because they're actually taking better care of themselves and interacting with their healthcare professionals.
And I think when you appreciate that and you go, okay, this is a diagnosis, but it doesn't have to have bad outcomes. It's something you have to deal with, and it's more than annoying, but it is quite an imposition. But it doesn't have to equal your baby's going to have problems when baby's born. And I think taking that out of the equation, saying, look, we're going to help you, and the vast majority of babies we would expect not to be affected by the gestational diabetes in a negative way, and for you to have a happy and healthy birth.
I want to ask a little bit about, quite interested in how the environment that babies grow in affects them when they're grown up. And I know there's a lot of sort of genetic programming that happens when babies are being grown. So there's loads of evidence to show that, people who are pregnant and they experience stress when they're pregnant, you can actually find raised levels of cortisol in babies when they're 6 weeks, which is wild, but also makes sense, right? Both of those things can be true. So how does having diabetes when you're a baby and you're inside your mum's stomach affect you when you're a grown-up?
I mean, this is a sort of a massive area, and it's really important to know, because it's what patients ask me all the time, because mums care about their babies. They want to know, how is this going to affect my child? There's two aspects. One aspect is that the genetic change that puts the mum at risk of diabetes is very likely to be similar to the baby, because the baby's got half of the same genetics as the mum. So that baby already is predisposed to themselves develop diabetes later. So I think you have to say, okay, you're sharing genetics. It's very likely, we say your baby would have a higher chance of that diabetes lifelong. So you've got the sort of almost pre-pregnancy risk. And then in terms of what we talk about with programming inside, what programming means is the environment that you're in affects how your genes are signaling. So I describe genes as a little bit like a recipe book. They're the instructions in a recipe book. They sort of tell you what to do. They tell you how your body's going to build. But epigenetics is this sort of way, the thing that tells you, it makes you do it. So it's you're in the kitchen, you're actually bringing the stuff out, you're actually making the cake that's in front of you. Epigenetics can change. The recipe book is unchanged, but actually how you and when you do that,
if you actually need a tablespoon or you
absolutely,
yeah, exactly.
That's what epigenetics is, and epigenetics is affected by the environment that you're in, and that's where we think the main reason behind some of this program effect is. So we know that there was a famine, the Dutch famine, hunger famine, where women didn't receive enough nutrients, and those babies were programmed inside to actually be better at getting nutrients. So in later life, they developed more fat tissue, they developed more propensity to diabetes. So you've got the kind of extreme lack of food, and then you've got the other end, and it seems to be almost like a U shape, that in the middle is the perfect bit, and then at both ends, if you have overnutrition, you're also programmed to develop kind of more of the consequences of overnutrition in later life. So more chance of things like higher blood pressure in late childhood, obesity, or even just a higher body mass index is programmed inside. So you've got, you want to be in that perfect middle bit.
Friends, I wanted to ask a little bit about who gets diabetes. Why is it that some people are more likely to get it? What are the factors and processes involved in that?
So we know that patients from certain ethnicities are more likely to get diabetes, so or gestational diabetes, and that's probably because of their ethnicity and associated changes in their genes. So, because some people are like, oh, is it dietary related? And I don't think it is dietary related. I think it's genetics. With different ethnicities is different. Your response to being pregnant, your ability to grow the baby is slightly different. So we certainly know that some ethnicities are at higher risk. Then we know that patients with a higher body mass index are more likely to get diabetes. People who've had diabetes before is the biggest risk factor. And older women are more likely to get diabetes. I've probably forgotten some. We test a few others. We always test our patients who've previously had a pregnancy loss. That's not particularly evidence-based, but there is an association with pregnancy loss with people who've had stillbirth. And type 1 or type 2 diabetes in particular. So here we offer this testing in case it was a previously undiagnosed diabetes as a cause. We know that patients with cholestasis of pregnancy, which is one of the other conditions that I research, are more likely to get gestational diabetes as well. So there are sort of some metabolic abnormalities like the dyslipidemias. There's the kind of weird and wonderfuls that are very rare, but you just use your brain cells when you've got those. And then you've got the very common things. There are some parts of the country, parts of the world where there's such a high prevalence of gestational diabetes within the patient population. They test every woman, and some patients that are much more kind of limited.
Okay, that makes sense, except for the one thing about ethnicity.
Yeah.
Because my understanding is that for so long, so the way I think about it is when we think of any sort of health conditions, we think of risk factors.
Yeah.
And it comes up as the kind of risk factors you can do something about, and the risk factors that you can't do anything about. So the modifiable and the non-modifiable. And often in the non-modifiable comes up ethnicity, right? So if you are South Asian, as a classic, I'm at high risk of developing diabetes. And there's nothing I can do about that because that is my ethnicity. My parents are my parents.
Yeah, no, you can't change.
I can't change my ethnicity. And for so long, we've been kind of trained to think that that is to do with, the main reason behind that risk is to do with genetics. But from my understanding, there's a lot of evidence that's coming up that's showing actually there's so much in the way that we experience life that is related to our ethnicity.
Yeah.
There is so much to do with, for example, not even just ethnicity, but if you look at people who've come from backgrounds of migration,
absolutely,
first generation of migrants, and actually it's not even needs to be related to ethnicity, just episodes of life that are quite stressful.
Yeah.
And this is, kind of what you related to what you're saying about the Dutch famine. And actually, if you have these times in life where you're feeling quite stressed, we are programmed to have our fight or flight response. And actually what happens is you have these high sustained levels of adrenaline and cortisol, and actually that's not very good for us. And that it was programmed for us to say, okay, I need to fight you, many years ago. But actually constantly being in this level of stress, and this could be to, actually, I've got mold in my house and no one's helping me get a new housing apartment. This could be, I've applied to all these jobs, but I can't get them. And I don't know what to do. Various amounts of stress. And that could be related to the colour of your skin, your ethnicity, your socioeconomic background, just where you live and work. And actually having this sustained period of stress gives you this allostatic load, which is basically a sustained period of stress for a long time. And that has profound impacts on epigenetics. So that affects how the recipes are read. And if you've got a genetic code, that affects how that code is read. And actually, maybe my understanding is that we don't fully understand how much is genetics and how much is environment. But what I found quite interesting is that for so long we've thought that genetics has the biggest part because it's easier for us to understand. But this bit about environment and epigenetics is a lot more, it's a lot messier.
And actually genetics is a lot messier as well. So we understand very little about genetics is the honest answer. So we understand big genes that turn production of something on or off. But actually genetics isn't on or off about one big protein. There's lots of sort of what we call SNPs. So very small changes in the genetic code that might not be on or off, that might affect the rate of production.
Dimmer switch.
Dimmer switch, brilliant. And there might be some dimmer switches that you can only switch on or off if you've pressed another button somewhere else that might not even be within the gene. But so I think we're learning a lot more about genomics. The other problem that we've done with genetics is historically most of our studies have been in Caucasian, European, white women. And then we've had a few people who have had very, very different genetic codes. From different ethnicities. And what we've actually really understood is that white European is a very narrow genome, and there is huge variation. So like you said, you're South Asian. Often you'll find in studies that people put together an Asian as a category, and the difference in the genetics between someone from North China, Malaysia, it's almost like two completely different things. And what we're really understanding is that we don't understand genetics either. So just like you said, epigenetics, programming, all this, we don't really understand. I think we also don't understand even what the recipe book we're reading from in the first place.
Makes sense. And how I've kind of put that all together in my head, trying to understand how does genetics affect my chance of developing diabetes, is that, do my parents have it? Because those are direct genetics, and yes, it could be related to ethnicity or not, but those are the genes that were passed on to me, and they both have diabetes. So, so from that I understand my genetic risk. But it's interesting what you're saying is that we don't really understand. When someone asks me why do I have it, it could be because of this and it could be because of that, but really we don't know. I think sometimes people expect us as doctors to have all the answers, and some of it is about what we know and what we don't know. How do you think our understanding of diabetes has changed over your career? Like, I feel like we know a lot more now than we did.
We do. I think we also know what we don't know a little bit more. I mean, part of our understanding with diabetes that's changed is gradually we have started offering treatment and intervention at lower and lower and lower thresholds, because we've recognised that it's actually a straight line. It's not like you don't have gestational diabetes or you do have gestational diabetes. It's a continuum, and it's very arbitrary. Do we put the line at 5.6? Do we put the line at 5.5? Do we do 5.1 if you're international? You sort of say, well, actually, it's not. Sort of my understanding really is that in a way, the lower the better, the more that we do the better, but actually it's how you deliver the service that you want to do. So slightly bizarrely, COVID has really helped us with that. So part of what we had to do with COVID was look at alternative ways to monitoring patients with gestational diabetes and say, you can't come into hospital. We can't ask you to come into hospital every single week for the rest of your pregnancy to show us a book with your blood glucose concentrations so we can circle the ones we don't like and tell you need to do something different. It's become much more patient-directed of saying, okay, you can have an app on your phone, you write in, or even actually your blood glucose meter might talk to it, and then you can contact us directly when you need to we can see what your blood glucose concentrations are doing, and you're getting always that direct thing. You've got coloured lines that tell you if it's a little bit too high or too low. And it's becoming more patient directed and getting faster feedback. So I think part of what's changed is we're diagnosing gestational diabetes in more patients at lower concentrations, but also I think we're changing ownership of the disease to being sort of paternalistic, the doctor's telling you what to do, to being patient directed.
Yeah, you can definitely see that as well. I think there's a move for people to, I think they feel more autonomous when they have control over. I mean, also those graphs are very helpful because I can look and I said, right, what did you eat? Potatoes? And then they start laughing. Because you can tell and you know when certain changes in your blood sugar has been related to diet, and they say, you know what, I had a really difficult day. I was just at work and I needed to eat. And I was like, that's okay. You know, like so these things happen. You can't. And also sometimes it feels a bit like you're telling this person, right, you can't eat anything. Now you must.
Yeah.
And how do you find kind of working with the patient, to work with them to give a plan or a way of being that works for them? Because it has to be variable, it has to be personalised.
Definitely. I mean, I think I'm in a very lucky position actually, because at the diabetes team that I work with are the people who very often might be seen as the baddies, who are like, you have to start insulin or you have to start treatment. Whereas I get to be like, right, okay, here are what your sugars have been doing. Actually, on your scan, your baby's growing beautifully. Did you have a really bad night's sleep that night? And often patients, when they have high blood sugars in the morning, will say, yeah, I was really stressed, I had a really bad night's sleep. I woke up 3 times, or maybe my 3-year-old came in and going, well, okay, that's probably why your sugars were there. And I've got the chance to understand with them why something's happened and say, what can we do about it? And, you know, it's very simple things sometimes. It's going, you know, Easter's coming up. Easter, you may be exposed to more things that you don't necessarily, that we wouldn't necessarily recommend. So, okay, if you're going to have something, what can you do to kind of reduce the effect it's going to have on your blood glucose? So we talk a lot about food pairing, putting carbohydrates with protein. So you're saying, okay, do you know, I'm not going to recommend it, but if you are going to have something that you know is likely to put your blood glucose up, can you do something about it? Can you go for a nice long walk afterwards, so that your skeletal muscles are the best thing at taking sugar up into your out of your blood? If you go for a walk up and down the stairs, you know, what are you going to do to actually make this teamwork? And I think much more than being me telling a patient what to do, it's saying, okay, this is about teamwork. This is about me giving you suggestions and making recommendations. But in the end, I can say anything. If you're not listening to me, you're not going to engage, and you're going to do whatever you want. And it's not my pregnancy, it's your pregnancy.
This is something that I feel actually quite strongly about in all of our patients. Is I think sometimes patients see us and they feel, if you're going to tell me I have to do this, do I have to do this? It's like, this is always your pregnancy, your baby. The decision is yours. If we think you're able to make decisions safely, make your decisions, that's yours. Our job is just to give you access to information to help make those decisions. Yeah. And I think people find that quite liberating. Yeah. Yeah. Because it is your decision and we're supposed to just give you information. And obviously, I guess the kind of information you get varies, right, from where you are and what kind of care you're accessing. I want to talk a little bit about induction of labour, about what it is, why it's relevant in gestational diabetes, and kind of when I have that conversation, which is a lot, probably more than you. A lot. I'm trying to explain why it is that we're recommending that, and what are the risks that we're reducing, and what are the risks that we're worried about.
Sure.
Can you?
Yeah. So I think so if somebody doesn't have gestational diabetes, let's just say any pregnant patient, we're recommended by the national guidelines to offer induction of labour to all of these patients at 41 weeks to reduce the risk of stillbirth for their baby, because we know that the more pregnant that you are, the older the placenta gets, so that there's an increased risk of stillbirth.
And there's good evidence for this, right?
There
is graph
that shows
that actually the risk of stillbirth goes up massively.
Yeah. So we could offer every pregnant woman an induction of labour at 24 weeks to prevent stillbirth, and that would work because our definition is from 24 weeks, but we would have an enormous number of very, very preterm babies, and that is not a good thing. So what we have to work out is, at some point between those two sort of gestations, what's the best time to have a baby? And the best time to have a baby is not the same for every patient. So you have to look at the patient in front of you and say, what risks do you have of induction of not being induced? So for patients with gestational diabetes, the vast majority of those patients don't have an increased risk of stillbirth over the background risk.
For most patients?
For most patients. There's recent data that came out of America where they looked at patient outcomes in sort of 1 million pregnancies. And that did show that where the babies are large for gestational age, so that means that they are, that with 97% of babies are smaller than them, and they're in that top 3% for their gestational age that they're born, those babies have a slightly increased risk of stillbirth.
Is that the weight? So the estimated weight
at birth.
At 36 weeks?
No, that's the weight at birth.
So the weight. So if the weight at birth is more than 97% of overall babies, that's associated with a high risk of stillbirth. That feels less serious than I had thought of the risk before.
Yes, and that's I think been part of the problem, that we've said to people that we are recommending an induction of labour to prevent your baby being stillborn. And if you say that, that's the most petrifying thing to say to somebody, and you'll feel like, God, of course, I definitely want my baby to be born now. For the vast majority of patients that I see with gestational diabetes with no other pregnancy complications, that's not the reason that I'm offering them an earlier induction of labour. The reason that I tend to offer patients with gestational diabetes an earlier induction of labour than waiting for them to go into spontaneous labour is to reduce birth injuries. So the bigger the baby, the more chance you are to get this perineal tearing towards the back passage, or for the baby to get stuck and have an injured collarbone. So that's the main reason why, if you have gestational diabetes, I would offer you induction of labour, because the earlier the baby's born, the smaller the baby will be, the lower the risk of birth injury.
So say it's me, I 40 weeks, and I have gestational diabetes, which I've been managing with my diet, and the graphs are showing you it's overall okay. I've learned how to take those long walks.
Well done.
And actually I'm feeling okay, and it's been recommended to me that because I have gestational diabetes, it's managed on diet, that I have an induction at 40 weeks. But the growth of my baby is actually okay. Why, if the growth is okay, why should I have an induction? What?
So here again, this is where you say it's your choice. The first thing is, this is why I'm recommending it. So scans are good, but they are not 100%. So the first thing we have to say is they are only as good as the accuracy of...
There's about 20% of
absolute
error.
Although, to be fair, I think with better scan machines, we're getting better and better.
Really?
Actually, I do think they're more accurate. But, you know, within the accuracy of scans, they're as accurate as they can be. So it's great that you've got a normally grown baby, and well done. And in terms of, you can choose not to have an induction, or you can have an induction. The reason that I would recommend an induction, or I would offer an induction at 40 weeks, is to reduce a risk of birth injury, even with a normally sized baby. So you said earlier that you can still have the shoulders getting stuck with a small baby. It's not always a large baby. So it's trying to reduce that risk. Then you sort of say, well, what happens if you don't have an induction of labour? Am I more likely to have a vaginal birth, for example? And I think that's been the perception, that induction of labour is associated with a higher chance of caesarean section. We've now had lots of different studies and lots of different patient groups that still not everybody accepts, and I appreciate it's controversial, but my interpretation of the evidence is that the smaller the baby, actually, the less likely you are to have caesarean section. So that's based on a study called the ARRIVE study, but also there's lots of others, 35, 39 study, loads of big, really big studies, that if you offer an earlier induction of labour to a woman who wants a vaginal birth, rather than waiting, you're less likely to end up with a caesarean section. Probably because your baby's a little bit smaller.
Interesting, because I think a common fear when you're talking about induction of labour is that if I have an induction of labour, I'm going to go down this route and I'm going to end up with a caesarean section. And what's the evidence about association with induction of labour? I guess this is not only diabetes and caesarean section.
Well, do you know, it's actually really interesting in diabetes, trying to get those data are very difficult. So what we did was we looked at our local data. We looked at what happens here. If you come to my hospital with the way that we look after,
that's what I counsel.
Do you know what? I think it's right. It's too broad, because a caesarean section is multifactorial of why it happens. There's, you know, you can't just say by chance does it happen or not. You know, does your baby have blonde hair or brown hair? Is chance. do you end up with a cesarean section? There's so many factors that are outside your control, what the doctors are like, what the policy is, how long does the wait tend to be, how to interpret CTGs, all these other factors.
And how your baby's doing in labour, which is the most unpredictable.
Absolutely. Yeah. So in terms of when we looked at our data, we looked at data from before the pandemic and after the pandemic, because as I said, I think there have been some changes in care. And what I found really helpful was looking at patients who were in labour, either because of an induction of labour or because of a spontaneous onset, so going into labour naturally, by each gestational week. And were they more likely to have a caesarean section if they were induced at that week or went into labour that week? And there was no difference. And more than 80% of our patients at every week between 36 weeks and 40 weeks had a vaginal birth where they started their labour off spontaneously or had an induction of labour.
80%.
More than 80%.
And this is the thing, it's quite nice to have the numbers to back up what you're saying, because I am trying to explain that with an induction of labour, we're actually copying what your body would do naturally. And what we're aiming for is the vaginal delivery. Obviously, the risk profile might change and our recommendation might change in labour. But I completely agree. It's so much easier to give your local statistics that if you are at this hospital, it's better to check in on those hospitals, because I know that where I was working just now, there was no increase in caesarean associated with induction. And we could say that because we had audited that and had the data. I am going to pause and check again on the floor. So, yeah, I read one of the things that I read, I think it's for the exams actually, that your association of stillbirth, if you've got diabetes in pregnancy, is 5 times more likely compared to the background risk. Is that true or false?
I'm going to go with false.
Yeah.
So
you're the expert. Yeah.
So we know for patients with type 1 or type 2 diabetes that about 1% of their babies are stillborn. So that's about 3 times the background stillbirth rate. And in terms of if you have gestational diabetes in a high or middle income country, most studies recently suggest that with actively managed disease, there's no increased risk of stillbirth. And that's how I used to counsel patients until last year when this American study came out that showed it was the patients with large babies and small babies that had higher risks of stillbirth than those with normally grown babies.
Interesting.
What is interesting is it's the large babies have a higher risk than the small babies. And as obstetricians, we're very familiar with small babies we worry about. We worry the placenta's not working well enough. They have scans every week. They have monitoring of their baby's heart rate. We deliver these babies early. And yet with gestational diabetes, if you have a small baby, yes, you have a higher risk of stillbirth, but not as much as if you have a large baby. And that is a different way of thinking. And I think when you understand that, it makes you just realise those few babies that you need to worry about a little bit more.
Is that in terms of the control of the diabetes, that's a big factor in it, right? Because
it's a factor, definitely.
Because if you've got poorly controlled diabetes, then your risk of stillbirth does go up. But maybe the reason why the risk is not as bad as we thought it was is because we've actually been better at managing people's blood sugars.
Yes, we're better at managing people's blood sugars. And also we talk about the earlier delivery. We were talking about induction. Why do we offer doing induction? You know, as we said, at 41 weeks, we see a real increase in the risk of stillbirth. We know that if we were to induce every pregnant woman, we probably need to induce about 1,000 women at 40 weeks or 39 weeks to prevent one stillbirth. But actually we have thousands and thousands of women with gestational diabetes who are being offered induction at this point. So we probably are preventing some of those non-diabetes related stillbirths as well.
How are we diagnosing diabetes, and when are we diagnosing it? Why is it then? And because it's diagnosed differently.
It is. Yeah. So the standard route is based on risk factor screening. So we talked a little bit about which patients are more at risk of gestational diabetes. So when you first see your midwife, they will take a history from you. They'll measure your height and weight and blood pressure. And they put together sort of all of those risks and they say, okay, you're at a slightly higher risk of gestational diabetes. So at about 24 to 28 weeks, we will recommend that you have a test to look at whether you're developing diabetes. That test is called an oral glucose tolerance test. And what we ask you to do is come in, usually to hospital, have a blood test when you're fasted, so you haven't had any food. You can have water but no food before. And then we give you a standard amount of glucose to drink. Which tastes disgusting. It used to be Lucozade, and then they reduced the amount of sugar in Lucozade, so now it's a sort of fixed formulated drink. with 75 grams of glucose in. And then 2 hours later, we measure your blood glucose and we see the numbers. And it's very easy to remember. 5, 6, 7, 8 are the numbers.
I remembered it for all exams.
Absolutely. So those are the UK numbers. Internationally, there's a different organisation called the IADPSG that recommends 5.1 and 8.5. So again, slightly depends where in the world you are. But if your number is that or above, then we would say that you have gestational diabetes. So that's the standard method of diagnosis. However, there are patients who may have glucose in their urine when they come to see. And one of the things that we always look for when you come in, every time we ask you to bring a urine sample so that we can check if there's glucose. And if there's glucose in your urine on 2 occasions or more than just a small amount, then we would recommend that you have glucose testing soon, not waiting until 24 to 28 weeks. So that's one of the things. Also, if you have a random blood glucose, so some places when you first book will do a little finger prick and test what your glucose is. If that's high as well, then that might indicate that you need to have glucose testing.
So I guess those are 3 kind of different ways we can find out if you have diabetes in pregnancy. But I guess the 4th is also when we see that babies may be growing big on scans and then we go back to check your glucose. So those are the 4 main ways. Why do we diagnose it differently in pregnancy? Because if you're outside of pregnancy, then we look at certain type of blood cells, right?
So we use this fixed test because it's the most evidence-based way, but I'm not sure that we will agree it's going to be the perfect way. That may change in future years. The reason that we don't use what we call HbA1c to diagnose it is because of the effect of pregnancy. So to understand that, HbA1c is the way that we look at how much glucose is stuck to your red blood cells. And that kind of, because the red blood cells last for 3 months, you can see over the 3 months how much glucose has been around. It's got stuck to your red cells, and it gives you a marker of what your glucose control has been previously. However, in pregnancy, you produce a lot more new blood cells, so they don't last for 3 months. You've got way more than that. So you have a little bit less glucose stuck to them. There's not the time for the glucose to get stuck there. So we don't have a good normal range or abnormal range for pregnancy at different gestational ages. So that's why we don't tend to use that. It's very helpful because if it's high, it can give us the indicator, but a normal level doesn't tell us that you don't have diabetes in pregnancy.
Got it. And that's because the turnover of how quickly you're producing the red blood cells is so quick.
Yes.
That makes sense. And in terms of, so you've being diagnosed with it and then monitoring it, lots of people don't like pricking their fingers every day. Is there an alternative?
So continuous glucose monitoring has been in the news a lot in terms of there's lots of famous people who use it for their pre-existing diabetes. There's also products that you can buy on the market, again using CGM, which is continuous glucose monitoring. And what it is it's a little, usually a sticker with a device that goes into, not to your blood itself, but just into the tissue, usually stuck behind your arm. And that measures the amount of glucose in what we call the interstitium, which is the area around your cells, just outside your blood vessels. So it's a really good marker, a good indicator of how much glucose there is in your blood. It can monitor it in different ways. Some of them you have at your phone and it connects with your phone, and it's called flash glucose monitoring. When you put your phone near there, it will see what your glucose level is and record it on your phone. Increasingly, we're getting continuous measurements. So rather than looking just when you want to check, it's all the time measuring. And it's incredibly helpful for patients with pre-existing diabetes. We've got really good evidence now that suggests that having this continuous glucose monitoring improves their glucose control in pregnancy. The challenge with gestational diabetes is we don't know what's normal, because everybody will have glucose that goes up and down. And that's normal. That's what your body should do. You eat something, your glucose will go up, and then you will produce insulin and it needs to come down. And so you can't ask for everybody to have every single recording within this target range, because that's not what your body does physiologically. So if you have that,
it's normal for it to be like that.
It's normal for it to be up and down, and that's what your body should do. It should go up and down. When it goes up, you produce insulin, you bring it down. When it goes down, you release new glucose and it comes up, and that's what your body should do. So if you have pre-existing diabetes, we want about 70% of your time to be within this target range, not 100%. If you have gestational diabetes, we don't know how much time should be in that target range. So it's really helpful it can give us some really nice information, and it particularly, it lets you personalize your diabetes.
This is what I found, because I found people saying, I don't want to prick it. And then some patients, if you say this is an alternative, I think it's helpful. So my understanding is that if you've got pre-existing diabetes, having your blood sugar monitored continuously, there's loads of evidence say that's really helpful. And I guess that's because we know what the thresholds are, that we want 70% of your sugars to be in this range. I don't think there's enough evidence for people who've got gestational diabetes, primarily because we haven't recommended it to lots of people. And we haven't got the studies on that. But I think just from a practical point of view, the kind of pros of it are that people feel, well, one, they don't have to prick themselves with a needle a few times a day, which for lots of people is a big win. Two, you're getting a lot more data, and then you can kind of feed that in with other stuff about, like you were saying, about how you're sleeping, what you've eaten, how you're moving, how you're feeling. So it's quite helpful. And I guess the third thing is there's an opportunity to then tailor things for you. Hey, we're noticing at 6 p.m. this is where your sugars are really high every day. So there must be something that we can kind of change. Let's look back and do that. So there's that opportunity to make really personalised care plans for people. But I guess then also the flip side, some of the cons of that, it could relate to a lot more health anxiety, because all of us have insulin. Like everyone is responding to the food that they eat. So if you're constantly looking at your phone and knowing, oh, my sugar's gone up, even though that's a normal thing it's supposed to do and come down, particularly when we don't know what is normal, we don't know that, it could actually make you feel not, just be a lot.
And that's the feedback that I've had from a number of different patients. So one of my patients said that she checked her monitoring 250 times a day. And you just think 250 times that, you can't live like that. You know?
Whoa, that's more than 10 times an hour. Which
yes, yeah. And then I had another patient who actually had pre-existing diabetes, who said that, yes, she liked the continuous glucose monitoring. It alarms when she's low or very high. But actually, when she just did the finger pricking, she in her head had the window between that she didn't have diabetes. She could just get on with her life. Yes, she had to check. And she'd been doing this for years. And she said, actually, with the continuous glucose monitoring, she was permanently a patient with diabetes. Whereas in the gaps in between, she was all... And that is interesting.
I've had similar feedback. So I had a patient who was I just want to know what's going on. And early on found it really helpful. And actually it really coincided with how she was feeling. So she would have sometimes really low blood sugar when she was feeling awful, which makes sense because she also collapsed when she had her glucose tolerance test. And then so she had a better idea. And then she said, now I've just stopped using it. And I'm not as anxious. I generally, if I know now that how I was feeling was related to my blood sugar, I can just listen to myself without this constant thing of, and it's a lot of pressure to put on yourself. And also there's this additional pressure that is for this person that you're growing. And there's loads of evidence to say that people are just generally, baseline anxiety is much higher in pregnancy. So there's this other thing with objective markers that we don't even fully understand. So I guess it comes down to what people want. And but there is an alternative if you didn't want to.
Yeah, and I think the important thing to say is if you have abnormal readings, it isn't measuring your blood glucose. So if there's something abnormal, you still need to do your finger prick and actually say, am I safe or not? Because if it's reading low, you do need to measure your real blood glucose to tell you that.
This is what, and actually, I call it calibrating it so that you actually know if this is the same as your blood sugar, basically.
Yes, because the continuous glucose monitors, they're calibrated to be within the reference range, is their target range. They're less accurate above or below, whereas your finger prick blood glucose, if they're calibrated at different, a wider calibration, so that it's more accurate at high and low levels.
I want to ask a bit about how diabetes is associated with other conditions in pregnancy. I feel you study other conditions in pregnancy, and kind of what are the conditions that they're associated with, and what's the kind of reasoning why they're kind of all connected?
So, I mean, the condition that I do most of my work in is cholestasis of pregnancy, which is a condition where bile acids in the blood go up. It's a metabolic disease. It's about how your liver handles bile, which is what goes into your gallbladder, helps you digest your fat, and kind of goes back round. It's produced from cholesterol, and it's we can't just think of it as detergent, but actually it's a molecule that goes around all of your body, and it affects how all of your cells signal how they respond to many things, including glucose.
This is bile acid.
This is bile acids. So cholestasis of pregnancy we know that it has about a 3-fold increased risk of women having diabetes as well in their pregnancy, because again, a little bit of a rise in your bile acids is normal in pregnancy. It's that being a bit too good at being pregnant. You just have a little bit too much. And then your body isn't able to handle all of your bile acids. And rather than going into the gut, they go round into the rest of your body, act on all your cells and make you not respond to insulin or glucose as much. And then you're more likely to get diabetes. So that's a condition as well. Other conditions like the dyslipidemias, where you have too much fat in your blood, they're very much involved with abnormalities in your glucose handling, because we only really talk about glucose with gestational diabetes, but that's not really true. It's also associated with abnormalities in the fats in your blood. It's just that we don't quite understand how they affect you and your baby so much, and how to alter them. That's why we focus on glucose. But it's probably a little bit of a simplification, that it's not just about glucose. It's a condition, a metabolic condition, that affects how your body handles fats, whether it's good fats or bad fats. You've probably heard about how you balance those.
I want to go back. What does it mean if something is a metabolic condition?
So the metabolism is basically how your body produces energy and how it uses energy stores to produce energy and how to store energy. So that's the simplest way that I describe metabolism. It's how every individual cell in your body stores enough nutrients to be able to then produce new energy, to release new energy, to function. So that's metabolism. And metabolism is controlled by signals, by hormonal signals mainly. And a hormone is something that's produced somewhere in the body that can travel around. Usually in the bloodstream, you can have more local signalling as well, but essentially it travels to an adjacent area and controls how those cells store and release energy.
So when you say that something is a metabolic condition in pregnancy, it's to do with the way that your body is taking in energy and producing energy. And when with diabetes, we focus a lot on blood sugar, but it actually affects lots of those signalling pathways, including how it stores and responds to fats.
Yes, absolutely.
And that kind of explains the kind of, I guess, overlap between conditions like cholestasis in pregnancy and diabetes. Kind of summarize, what are the things that you can do if you've been diagnosed with diabetes during your pregnancy? Tips. You've just got a diagnosis, you're feeling overwhelmed. What are the practical things you can do?
So I think practical things you can do if you've got gestational diabetes. Firstly, understand what happens to you. So we asked you to monitor blood sugar levels, keep a diary of just what you're eating, put it on your phone. It doesn't really matter what you do with it, but just have an idea, because if you understand what tends to put your sugars up, then you know how to modify that. I love talking about food pairing. I love the fact, probably because I quite like food, but I love the fact that if you have protein with carbohydrate, you don't get the spike in blood glucose that you would have if you ate exactly the same carbohydrate. So just by themselves. So I sort of describe, if you're having strawberries, have them with yogurt, and you will find your sugars don't go up in the same way that if you just had the strawberries. So dietary modifications are important. I think you also have to say, with these modifications, we still want you to eat, because there are some patients that are so concerned that their blood glucose stays perfect that they stop eating, and that's not what we want. Yes, you're going to have to change potentially portion sizes, your choice of foods, modifying things, but still keep eating. And if you cannot keep eating and have blood glucose concentrations within what we would like, the target range, starting medication is an option. And actually, we have probably about 60% of our patients with diabetes will require some form of medication. And if you need it, there's evidence, that's good evidence, that it will improve your outcomes in terms of the size of the baby. So if you need medication, I would say we're happy that it's better to have medication than not.
Yeah.
Obviously, if you don't need it, perfect, great. That's the ideal, because, the less medication that you have and you're exposed to, the better. But actually, it's better to have medication than not have medication if you need it. So I guess that's my kind of simple tips. And then I love exercise. So I love the fact that if you want...
I'm not sure anyone else can say
well, no, I don't. Personally, I'm quite a hypocrite, really. I do love the fact that you can, after you eat food, if you do exercise, you can keep your blood glucose much lower than if you didn't do any exercise. And it doesn't have to be hardcore exercise, but keeping your body moving, particularly in that post-food period of time, going for a walk, getting fresh air, get some vitamin D, enjoy the sunshine. Doesn't really matter what it is, but actually it's going to make you feel better. If you've got a kid, they need to go outside. They always need to be outside. And often you will find that that's a really good way to say, right, how can we bring looking after the diabetes into our family life? And well, let's put it part of the routine. After a meal, let's go out for, some fresh air. If I'm going to go out, let me have a snack before I go out, not when I come back through the door. Just trying to fit it around your life.
So it seems like the things you can do are, one, have a better understanding. So understand what this means for you in terms of, what kind of things you need to measure and monitor. Have a better understanding of now who's looking after your care, who are the doctors that are responsible for your care, for example, and have a better understanding of even just having a better record of what's going into your body and what you're eating and how that corresponds to sugars. So understand a bit better. And then it seems like pairing is key, a good tip from you. So you're pairing, if you are having carbohydrates, pair them with proteins because it's less likely to spike your blood sugar, but then pair your meals with exercise as well. And if you can do that whenever you can and fit that into your daily routine with your family and all the other responsibilities that you will have. But those are two kind of things. So better understand what's happening and trying to modify the way that you're eating and the way that eating fits in with your life. So whether that's attaching it to protein or walking and fitting in some sort of exercise.
The other thing is asking for help. So you have a team of people who love diabetes. We don't do diabetes.
I don't think there's anybody that loves diabetes as much as you.
Oh, no, I'm sure
there are some people.
Oh, we love diabetes. We're interested. And I learn from patients all the time. But I am not the expert about diet. My dietitian, she's not my dietitian. The dietitians in the, they're the expert. They really understand. Understanding how your blood glucose response is likely to be affected by the different choices of treatment, whether it would be tablets or insulin. Diabetes physicians understand that much, much better than the obstetricians. As an obstetrician, what I really like about diabetes is being able to say, okay, so this is diabetes. How is it going to affect your baby? How is it going to affect your birth? How can we actually make the post-birth process as good as possible? And what I really love about diabetes is not only is it you're too good at being pregnant, but my recommendation is after you've given birth, how can you help your baby to have a lovely stable blood glucose in that first few hours? Actually, early skin-to-skin contact, early breastfeeding, almost more normal than normal post-birth is more important for your baby. So from my perspective, I want to support you expressing colostrum before you give birth to have it available. I want you to be in a calm position where if your baby is against your chest, their temperature regulates, their blood glucose levels regulate. Actually, they're much less likely to have any complications of being born because you're normal. And I think trying to kind of maintain that normality is what I love about it.
I've seen people who have read things and are a bit worried. I've seen people in clinic who are, I'm really worried. I think I'm going to struggle with breastfeeding because now I've got diabetes. And I try to kind of explain that there isn't evidence to show that the change from colostrum, the kind of pre-breast milk, into mature breast milk, there is a bit of it is associated with a slower process. But you can do things like from the first 6 weeks, actually try and harvest your colostrum. So if we know that bit of information, there are things that we can do.
Definitely. And I have to say, we oversimplify with colostrum. We ask patients to harvest their colostrum, freeze it, bring it in, so they've got it if their baby can't feed quickly, so their baby's blood sugars don't drop down too much. And that's great. But actually, I'd prefer that you don't need it at all. I'd prefer that your baby latches on beautifully, feeds, and that's our perfect world. But what we have good evidence as is if you harvest your colostrum before, you're more likely to leave the hospital breastfeeding your baby. That's the evidence. So actually we talk about baby's blood glucose control and all this sort of stuff, but what we can really say is if you start harvesting before, you're more likely to establish exclusive breastfeeding early on.
I guess there's also a lot of pressure for people to breastfeed, and it's not possible for everyone. And there is support out there if you're unable to, or even if it's not even that you're unable to, you just need a bit of help in that period of time. And I think that seems to be a common thing. People are like, I'm just expected to know what to do and I don't know what to do. And there are experts out there. There is help available. And there is also a group of people who are not able to breastfeed, and that is also okay.
Definitely. Fed is best is the most important thing. Your baby needs food.
Yeah.
And actually, like we said about holding your baby, it might seem very superficial, but it's really important in the baby's regulation of their metabolism, the way that they produce new energy. It's not the same as when you're an adult. And actually, that heartbeat that the baby's listened to for 9 months, that they can hear through your chest, is one of their self-regulation mechanisms. The voice. There's lots of evidence in very extreme preterm babies of what we call kangaroo care, where having preterm babies with mothers or with parents, about families, it's not just about the mother, they have much better outcomes, that it's really good for them. So just being a parent is more than any doctor can do. We can't do that. And actually that's where this normality, it sounds, normal's a dreadful word. It's actually that it's always the best kind of care that you can have, is really helpful. So if you're not breastfeeding your baby, you're still giving so much support to your baby. Yes, breastfeeding, we like to support patients who want to breastfeed with breastfeeding, and you should feel empowered with gestational diabetes to say, okay, I've had this condition that means my baby needs me to be able to breastfeed. If I want to be able to breastfeed, please help me a little bit more. And where we say early breastfeeding, doesn't mean anything at all. It's just a word that we try to kind of say, please get extra help with earlier rather than later. But, it's the same with if you're going to feed with formula, actually having the support to say, this is when my baby needs formula. Nobody knows that when their baby's first born.
Yeah. It's both interesting and quite nice that the familiarity of your heartbeat is one of the things that that's what your baby's been used to for all the months they've been inside. And for preterm babies, that helps them kind of self-regulate.
Yes. Yeah, very much so. And I always say it's a bit of an old wives' tale that if you tap the baby's bottom when you're cuddling them up here, but it's the rhythm of your heartbeat, and that's what they've been listening to, and it soothes them. You can tell I'm doing it now. My children are very old, but I can still do
whenever
that.
I have babies, I always do that.
Yeah, and it's that rhythm. So lots of these not evidence-based things, very much old wives' tales, but when you think about the logic behind them, actually it makes a lot of sense.
And also, I think if there's no harm in any of those things, then why not?
Yeah.
If it's also making you more relaxed and it's no harm, not harmful to baby, then why not? Yeah. What do you think is the most kind of important thing for people to know? For one thing, I've got diabetes, that maybe people don't understand that well, or is there a misconception? The kind of one thing that you want to kind of cut through.
You haven't caused your diabetes. I think that's the one thing I really, really want patients to go away from this, is to say it's not your fault.
Do you know how many times I heard I was on holiday and I just ate loads of cake? And I think that's why it's happened. No. Yeah. Your body is supposed to be able to manage eating cake.
Amazing.
Thank you.